Today we are Group 8 and today we will be presenting our case study on chikungunya. I am Gabrielle Domingo and together with me are my fellow members, Mercy ABAGA, Tricia DIAZ, Marc ECHAVEZ, and Sofia ESGUERRA. Our case is of a 28-year-old female teacher who recently traveled to Lopburi, Thailand, which is an area with no outbreak of this disease. During day one, as she returns from her 2-week vacation, she experiences mild fever, headache, and joint pain, which she attributed to the symptoms of travel fatigue. But during the following day, she developed a rash that spread from her face to the rest of her body, along with the presence of conjunctivitis. So, with this, she visited her primary care physician. According to her history, she also had a recent trip to Brazil where the virus is endemic. She reported that she acquired mosquito bites during her stay. So with these, she was tested for the following: dengue fever, chikungunya, rubella, measles, and allergic reaction. And among all of these, it is highly suspected that what the client has is chikungunya, especially with the reports of her travel to Thailand and Brazil, which are places that are known to harbor the virus. The reasons for chikungunya being the chosen disease will further be elaborated as we go through the discussion. So for now, I will be giving a brief definition of chikungunya. It is also known as chikungunya virus disease or chikungunya fever. It is a mosquito-borne viral disease caused by the chikungunya virus. It is also an RNA virus in the alphavirus genus of the family Togaviridae. Its name chikungunya was derived from a word in the Kimakonde language that means to be contorted. And now for its signs and symptoms. Here are its most common ones. So we have fever, chills, headache, rashes, joint pain or arthralgia, and sometimes patients may also present with conjunctivitis, nausea, and even vomiting.
In terms of the clinical and public health history, chikungunya virus was discovered in 1952 and is an arbovirus primarily transmitted to humans through Aedes mosquitoes. The first case recorded was in Makonde, Tanzania, which was then followed by the outbreak in Thailand in 1967 and during the 1970s in India. Over the years, it has spread to over 110 countries, including regions in Asia, Africa, Europe, and America. The virus first surfaced in the Philippines in 1968 among the U.S. Peace Corps. Initially, cases were reported in Mindanao, Cebu, and Masbate between 1985 and 1986. The diagnosis was confirmed through the isolation of the virus from blood samples of the affected patients, all of whom exhibited similar symptoms. Historically, chikungunya cases in the Philippines have shown seasonal peaks from June to September, coinciding with the rainy season. This period sees heightened transmission due to increased mosquito activity. Factors contributing to its spread include limited mosquito control measures, densely populated areas, and the lack or absence of vaccines. Though as of 2023, there has been a notable decrease in chikungunya cases in the Philippines. Chikungunya virus has multiple similarities with other different diseases such as dengue, Zika, and yellow fever. First is dengue fever, which is also transmitted by Aedes mosquitoes and is endemic in tropical and subtropical regions globally. Its symptoms include fever, headache, joint and muscle pain, and rash. Dengue can progress to severe forms with hemorrhagic manifestations, making early diagnosis crucial. Second is Zika virus, which is transmitted primarily by Aedes aegypti mosquitoes and has been outbreaks in Southeast Asia, the Americas, and the Pacific Islands. Zika infections are often asymptomatic or present with mild symptoms such as fever, rash, joint pain, and conjunctivitis. Notably, Zika infection during pregnancy can lead to severe birth defects like microcephaly. Third is yellow fever, which is also transmitted by Aedes mosquitoes and is endemic in tropical regions of Africa and South Africa. Its symptoms include fever, muscle pain, headache, chills, loss of appetite, and nausea. Severe cases may progress to jaundice, bleeding disorders, and organ failure, necessitating vaccination for prevention. With all these being said, chikungunya shares similar transmission vectors with dengue, Zika, and yellow fever. However, its distinct feature of prolonged joint pain sets it apart.
As mentioned earlier, infected mosquitoes, particularly from the genus Aedes, are the cause of chikungunya virus transmission. However, they are also responsible for transmission of dengue, yellow fever, and Zika virus, which makes clinical workers to not simply take a guess of the patient's potential disease. Hence, these are tests done to accurately diagnose a positive chikungunya patient. First up is RT-PCR test, or what we call real-time reverse transcriptase polymerase chain reaction test. This test is done to detect chikungunya RNA to potential positive chikungunya patients. Studies reveals that chikungunya RNA are widely present during the first week onset of the symptoms. Another diagnostic tool is ELISA, or enzyme-linked immunosorbent assays, a serological test to detect IgM and IgG antibodies on the patient. Every human body produces antibodies to defend itself. Hence, detection of IgM and IgG antibodies means that the patient is currently battling the chikungunya infection.
The highly accurate test we can use to diagnose chikungunya virus is the RT-PCR test, or real-time reverse transcriptase polymerase chain reaction. It checks the patient's blood for the presence of chikungunya virus itself. It is the gold standard or the most reliable test for this particular virus for diagnosing chikungunya, especially early on in the infection. Unfortunately, there is no specific antiviral medication for chikungunya. However, we can focus on managing the patient's symptoms. We can use pain relievers like acetaminophen or ibuprofen to help with the fever, headache, and joint pain. Antihistamines like diphenhydramine can also help with the itching associated with the rash. Most importantly, staying hydrated and getting plenty of rest are crucial for recovery.
So, here are some risk factors associated with the occurrence of chikungunya. First up is living or traveling to tropical or subtropical countries. Mosquitoes tend to live in a tropical environment with warm temperature and moist air, which makes it ideal for them to live. Furthermore, it was noted that the patient traveled to Brazil, where the virus was endemic. Hence, the patient should be aware of her surroundings. Secondly is intermittent usage of mosquito repellent. The patient mentioned that she wore mosquito repellent intermittently, knowing the fact that there was a viral endemic happening in the place, which has increased the risk of her getting bitten. Thirdly is usage of bed net when sleeping. Using a bed net can also decrease the risk of acquiring mosquito bites, especially when we are unconscious or asleep, as we cannot pimp the mosquitoes. And lastly is a weak immune system. Having a weakened immune system greatly attributes to higher possibility of acquiring the infection, as the host immune system is not strong enough to produce antibodies needed to defend its body.
Now let us proceed to discussing how the chikungunya cases in the Philippines have surged significantly in recent years. In 2023, there was a 381% increase in reported cases compared to the previous year, totaling 2,854 cases by the end of the year. Next, the gathered data are from the year 2012 and 2013, since we can't find recent data with the specific information of the prevalence and demographic. Furthermore, the highest incidence and prevalence of chikungunya are found in Region 11, Region 5, Region 10, Region 6, and Caraga region. Given that these regions are ideal for Aedes mosquito hatching, which is how the chikungunya virus is mostly transmitted. In the year 2012, the notable areas include Region 11, Davao Region, which recorded the highest prevalence rate at 2.82 per 100,000 people, and Region 5, Bicol Region, with a prevalence rate of 1.46 per 100,000 individuals. Region 10, Northern Mindanao, also reported a prevalence rate of 1.26 per 100,000 individuals in the same year. In the year 2013, Region 6, Western Visayas, reported a prevalence rate of 2.46 per 100,000 individuals, marking it as one of the regions with the highest number of cases. Region 4B, Mimaropa, had a prevalence rate of 2.40 per 100,000 individuals. And lastly, Caraga region also saw a high prevalence rate of 1.85 per 100,000 individuals in 2013. The demographic data of chikungunya cases in the Philippines indicate that women and adults are more frequently affected by the disease. In 2012, 68.9% of the reported cases were women, mirroring trends observed in other regions. The greater prevalence among women stems from the heightened likelihood of encountering mosquito bites during domestic tasks. Adults, particularly those 21 years old and above, also face higher susceptibility, notably affecting individuals aged 31 to 40. This pattern aligns with finding from other areas where adults' outdoor activity during peak mosquito times elevate their risk of infection. In terms of mortality and morbidity, chikungunya is rarely fatal. There have been no significant reports of death attributed to chikungunya in the recent statistics, emphasizing its status as a non-lethal disease. However, next slide please. The disease significantly affects morbidity due to symptoms such as severe joint pain, fever, and rash. Many patients experience prolonged joint pain that can last for weeks, months, and even years, leading to decreased quality of life. So, here are the levels of intervention applicable. These interventions encompass a comprehensive approach to disease management, from primordial measures that address root causes and community awareness, such as improve sanitation, control mosquito breeding sites, and promoting community awareness. To primary interventions, these includes vector control measures and promoting personal protective measures. And secondary strategies includes surveillance systems, recognizing symptoms, and accessing to appropriate medical care. And lastly, tertiary interventions include managing long-term health, which affects the person, and such as physical therapy, ongoing medical care. These multi-level strategy is important for effectively reducing disease incidence, mitigating impact, and improving the overall public health outcomes. Lastly, shown on the screen are the references used in our case study. Thank you all for your time and attention during our group's discussion.